All right, so this is case studies in managing pain. Why don't we just jump right in? California Bridge is a program of the Public Health Institute, which receives funding from the California Department of Public Health. I have no financial disclosures. California Bridge has no financial disclosures. I may use a trade name like Tylenol. It's just kind of out of habit. So if you're unfamiliar with California Bridge, there's actually three pillars of our philosophy. The first is low barrier treatment. And that's really letting the patient access medications where they are, whether they're in the ER, the urgent care, or the hospital and primary care clinics. The second is then connecting them to longitudinal care. An ER doctor has to be able to baton pass the patient to somebody. And that's where the navigators in the hospitals are really key to getting that linkage to low barrier maintenance treatment for the patient. And then the third is culture of harm reduction. That's really having kind of open arm approach, destigmatizing approach, and offering things like Narcan and fentanyl test strips. So the goal of California Bridge is 24/7 access to high quality treatment of substance use disorders in all California hospitals and now nationwide. California Bridge is now known as Bridge to Treatment, and they're doing the same great work they did in California across the country. So diving into pain lasting more than about 3 months affects 1 out of every 4 people in the United States. It's a huge burden. Pain is often ignored or underrepresented in healthcare. I bet if you went to your local hospital, you would probably find a cardiologist or a neurologist, but you'd be hard pressed to find a pain specialist. Pain should be considered a chronic condition of its own right, and the goals should be really centered on improving function and the quality of life. So let's start with a case. You have a 24-year-old female with an injured ankle. She was roller skating. It's swollen, bruised. She can't walk. She appears like she's in a lot of pain. How can we manage our pain, and what are the important points to remember about acute pain management? Well, the first is we really want to start with non-pharmacological ways of treating pain. We do this for acute or chronic pain. So in this case, maybe elevation and ice for sprains and fractures, maybe heat for acute low back strains, crutches, canes, splints, wraps, braces, stretching exercises. I want to say a shout out to the navigators in the room, and this is where you can really be an advocate. A lot of times doctors and nurses get focused on getting orthopedics and let's get this person to x-ray, and they forget about the little things that can really make a difference. And so reach out to your nurses and say, hey, can I get this guy in an ACE wrap? Can I put his ankle under a pillow? It's those little things that sometimes get forgotten, and you can be a big advocate for that. If that patient had to get admitted to the hospital, they've got a bad fracture, they're going to the OR, the first thing we want to do is really set expectations for the patient. You're going to the operating room, we're going to fix your ankle, but you're going to have pain afterwards. Our job is to make that pain more tolerable, more manageable. And so set that expectation. There's little things that patients can get that can really help with their hospital and pain experience. Things like eye masks, lip balms, an extra pillow, ice packs. There's something called mindfulness training, which we'll talk about. And when you take social workers who are trained in it and you teach the patient for about 15 minutes, studies have shown they just had brief teaching of mindfulness training, which generally takes about 8 weeks, but you just do it for about 15 minutes with a trained social worker, you can decrease the patient's pain scores and they use fewer opioids. Things like TENS units, acupressures, even just a hand massage can really help lower a patient's pain scores or in the hospital. Things like a virtual reality goggles, those things you put on and they take you to kind of Neverland places have been really found to be helpful for kids getting procedures and adults. And then things like music or nature sounds. There's a lot of things on YouTube, a lot of music therapy. You can download those things, create a QR code. And again, this is a shout out to the navigators. Be an advocate. Work with your hospital, work with your emergency department, put together a little brochure that has things that the patient can ask of the nursing staff. Hey, can I get that eye mask? Can I get an extra pillow? How about that TENS unit? Download some music therapy, download some things from YouTube, make some QR codes, put them on the brochure. Patients a lot of times have their own smartphone, so they should be able to use it. Been found to really, really be helpful. So when you measure acute pain, we really should be focusing on taking that severe pain to manageable pain. The problem is we use these 0 to 10 scales, and we allow someone who has a shattered ankle or has appendicitis to come in and say, I'd like my pain to be 0, please. Well, that's completely crazy. It's unrealistic, and it's very dangerous. The doctor would have to give a lot of pain medication, probably snow the patient, for them to have a pain score of 0. Super dangerous. It's much better we talk about tolerable pain, and that's where we need need to empower our nurses to have some talking points to say, you know what, I understand you're having pain. 0 would be dangerous. The doctor would have to give you so much pain, pain medication, it would get on the dangerous side. Let's talk about manageable pain. How about a 3 or a 4? And patients are usually agreeable to that. In fact, some hospitals make it as kind of a goal to have fewer patients or a lower percentage of patients actually asking for a 0 pain on the pain scale. Better questions to ask would probably be, are you able to take a deep breath? Are you able to walk around? Are you able to sleep? You'll see on there is what's known as the DVPRS scale. This is by the Department of Defense. The VA uses this. Anybody can adopt it. The large organization I work for in Los Angeles is now adopting this as kind of the pain scale they use. You can see it's got the traditional 0 to 10. It's got the happy faces, sad faces, but it also has some verbiage at the bottom that really talks to the patient. So maybe a 9 is, I can't bear the pain. I'm unable to do anything. 6, it kind of interrupts some activities. Maybe down to a 2, I notice a pain, but it doesn't interfere really with my activities. It gives more explanation of what that pain scale means in regard to function and ability to kind of enjoy life. Now we're moving into medications. You'll see acetaminophen and ibuprofen really are at the forefront. And these are just a list of kind of the acute pain situations you might see in an urgent care in your clinic where NSAIDs, acetaminophen, or the combination of have really been shown to be as effective or even more effective than opioids. You look down at that bottom, fractures, a gram of Tylenol and 400 of ibuprofen in combination has been shown to be as equally effective as a Norco or a Vicodin. The maximum amount of acetaminophen in a healthy liver is about 4 grams a day. Ibuprofen, I generally stick to about 400 milligrams as a dose. Once you get to 600 or 800 milligrams, there's probably not a lot more anti-inflammatory effect, but you're just really kind of getting more GI side effects. And then you can see the maximum amount per day in a healthy kidney. So just because it's over the counter doesn't mean it's not effective. Now, what if you have a patient who comes in with pain? They also have liver disease or renal disease, or they're older. Kind of a little bit of nuanced change that we need to think about. So acetaminophen in liver, the acetaminophen in patient with liver disease is actually safer than NSAIDs. So sometimes in patients with NSAIDs, they get a lot of renal bleeding and GI bleeding, and opioids can actually precipitate hepatic encephalopathy in these patients. So the maximum in a patient with cirrhosis is about 2 grams a day. Remember that healthy livers is about 4 grams a day. So if you limit yourself to that, you're probably going to be pretty safe with that patient. You want to be more cautious, though, if the patient continues to drink, if they're malnourished, if they're fasting, or if they have any type of hemodynamic instability, just because there's less blood flow to the liver that's already kind of compromised. Now, whenever you're educating someone about acetaminophen, you really want to be cautious about the other medications the patient might have in their toolbox. Something like a Tylenol or an over-the-counter cold medicine might also have Tylenol in it. So make sure the patient is accounting for all of the Tylenol they might be seeing in a day and making sure that it's less than 2 grams. What about NSAIDs and renal function? So one of the things that NSAIDs do is block prostaglandins. That's why it's really, really good for renal colic, because it kind of stops that spasm. The problem is prostaglandins, and prostaglandins are like these chemical-like hormone. They're hormone-like chemicals in the body. And one of the things they do is they assist kidneys that are already kind of reduced in their renal function. They help with the blood flow. They help with the renal perfusion. So if you take a kidney that's already got reduced renal function, and now you add an NSAID, now you're compromising that renal blood flow. And so you're now at risk for what's known as acute kidney injury, AKI, on top of the kidney, disease the patient already has, interstitial nephritis, renal necrosis, not stuff that you want to have. So we use what's known as the GFR, which is the renal kind of function of the kidney. Anything greater than 90 is considered normal. If it's mildly depressed, 60 to 90, prolonged use of NSAIDs is not recommended, but certainly short use can be good, the lowest dose that we can go with, and then kind of monitoring that GFR as we go along. If it's more suppressed and the GFR is 30 to 59, they really recommend to avoid prolonged use at all of the NSAIDs, and then kind of on a case-by-case basis with shared decision making with the patient, a short-term course is probably okay. Again, kind of checking that GFR. And then if the kidneys are really compromised, the GFR is less than 30, NSAIDs are not recommended at all. There's something called the triple whammy, which I heard about a couple of times in different articles, and that's the combination of an ACE inhibitor and a diuretic. Maybe the kidneys aren't compromised right now, but you throw on an NSAID, and that's the triple medications that really can kind of compromise those kidneys. You want to be careful in a cardiac patient that you're Also kind of throwing in that NSAID. You want to be cautious in patients who have known congestive heart failure, patients with known cirrhosis or with ascites, and then patients that are volume depleted because they just have kind of less blood flow going to the kidney on a good day, even if their GFR is not all that out of whack. And so you want to really be careful in prolonged NSAIDs in those patients. Topical NSAIDs carry a lot less risk, and so they're recommended for patients with decreased renal function. They're not perfect, but they're absorbing a lot less than they would if they were taking the medication orally. So if NSAIDs orally are going to be used, you want to make sure you use the lowest dose for the shortest period of time, make sure the patient keeps hydrated, and make sure that you're checking kind of that GFR frequently. There's a medication called celecoxib. It's what's known as a selective COX-2 inhibitor. More relatively new compared to the non-selective NSAIDs that have been around for decades. We'll talk a little bit more when we talk to about older patients in the next slide. But celecoxib, or this selective COX-2 inhibitor, it's thought to have a little bit in some studies more renal protection than the non-selective NSAIDs, but it's not perfect. You still have to kind of watch their GFR and be careful. So what if the patient's a little older? And we know that older patients run the risk of GI complications, acute kidney injury, heart attacks, strokes, when they have prolonged NSAID use. The American Geriatric Society puts out what's known as the Beers criteria. And they do this every few years. They look at hypertensive meds, diabetic meds, psych meds, all sorts of medication. And they see, in regard to older patients, how long should they be on it? Which one should they use? What dose is right? And so their recommendations for NSAIDs in older patients is really to use the topical NSAID, so that, getting that NSAID cream right on the shoulder, right on the knee, or using what are known as these COX-2 selective NSAIDs, but also some GI protection like a PPI. So what is this COX-2 selective NSAID? So NSAIDs also inhibit what are known as COX enzymes. One COX enzyme, COX number 1, protects the stomach lining, so it's good. COX-2 enzymes actually trigger pain and inflammation, so that's bad. The non-selective NSAIDs, like ibuprofen, attack both of these enzymes. They're really kind of inhibiting both of these enzymes. So they really do a number on the stomach lining, but they're also getting the pain and inflammation. The newer NSAIDs, these COX-2 selective enzymes, like celecoxib, really target that COX-2 enzyme. So they're just really going after the triggering of the pain and inflammation and kind of tamping that down. They're not really going after the COX-1. Is it perfect? No. You still can have some GI problems with the COX-2. So you still want to be careful, but at least for older patients, that would probably be the NSAID that I would choose over something like ibuprofen. Meloxicam is an NSAID. It's kind of considered in the middle. At lower doses, it focuses much more on the COX-2 enzyme, so really going after that pain and inflammation. But once you start bumping up to the higher levels of daily meloxicam, now you start getting more kind of COX-1 activity, and you have to really be careful of the stomach lining. And then if somebody is also on aspirin, so let's say you put them on an NSAID like a COX-2 selective, you're thinking, oh, I've got good stomach protection. And now the cardiologist threw them on some aspirin, all bets go out the window. Now they're kind of at risk for that stomach upset. So make sure you know about all of the medication that your patients are taking. So opioids, I think one of the big messages that came out of the 2022 guidelines that we talked about in April was that a patient does not have to fail non-opioids in order to be prescribed an opioid for acute severe pain. That was kind of the mistake that people came out of the 2016 guidelines, thinking I have to go through all these non-opioids in order to even prescribe an opioid. There are going to be some people that you're going to see with a shattered ankle. Maybe they're going into surgery. Those are people that are going to need an opioid. And so we want to be careful about prescribing it. Sure, we're going to do all that non-opioid, non-pharmacologic ways of treating pain, but they're also probably going to need opioids right from the outset. When you then go to prescribe opiates for the patient is where you want to do the shared decision making. You want to make sure that the patient, understands the risks of daily opioid taking, opioid medication. So there's always unintended long-term use. There's always the risk of an opiate use disorder. There's risks of respiratory depression, GI effects, drowsiness. At some point, if a patient takes medication long enough, and generally after a week, even just 7 days of taking a daily opioid, some patients will develop what's known as physical dependency. That if you take that opioid away, then now they're in withdrawal. Obviously, the larger amounts of opioids or the longer that they're taking them, and certainly if they go to higher things like heroin and fentanyl, those withdrawal symptoms are even more. But I want to make sure people understand that even with Norco, written as prescribed by a physician, taken for more than 7 days, can result in physical dependence. So generally writing for less than 3-5 days, we'll talk about it, is kind of preferred for acute pain. They develop tolerance. This is true for any opioids, even if you prescribe, a patient takes it as prescribed by a doctor, meaning you're going to need more and more opioids down the line to treat that same level of pain. That's tolerance. Both of these things happen with opioids naturally, even if prescribed and taken as prescribed by a doctor. Obviously, if the person uses vehicles or heavy machinery, you have to be cautious when they first starting opioids. If they do a job where the urine drug screen is done pretty routinely, they need to know that it's probably going to show up there. If the patient is still drinking or uses benzos, that can be a dangerous situation. You want to make sure that children and teens are protected from getting this stuff, and so making sure that it's locked up, and you don't want to share your medication. We really want to consider opioids only if the expected benefits for pain and function really outweigh the risks. So if you are going to prescribe an opioid, and we talked about this back in April, the recommendation for acute pain is immediate release short-acting opioids, things like oxycodone or hydrocodone. Long-acting medications like OxyContin or MS-Contin really don't play a part in acute pain management. We need to save those for our palliative care, end-of-life patients that are really kind of on long-acting opioids with maybe some short-acting kind of for breakthrough pain. We need to stick, for most patients for acute pain, is this kind of short-acting medications. Then you need to go to the effective dose, and the recommendations there are less than what are known as 5 MMEs per dose, and then less than about 20 to 30 MMEs per day. So what the heck is an MME? So morphine milligram equivalent is what we're talking about. It's a way of kind of comparing apples and oranges. So they give morphine a score of 1, and then they compare all the other opioids that are prescribed to morphine. So oxycodone, for example, gets a score of 1.5. It's a little bit more potent, a little bit stronger than morphine itself. So if I'm going to prescribe an oxycodone tablet of 5, and there's these MME calculators that you can find online, an oxycodone tablet of 5, if I multiply that times 1.5, that single tablet, 5 milligram tablet, has an MME score of 7.5. If I then prescribe it 4 times a day, so taken every 6 hours, 4 times 7.5 is 30. That's really the upper limit of the total amount of opioids that is recommended for a patient with acute pain. So not only per dose, but the total amount per day. And then the number of days, generally about 3 to 5 days. We don't want to get over that 7-day mark because, again, some people will develop a physical dependency. The longer you take an opioid, the higher the chance you're going to still be on opioids months from now. And they probably need a recheck. If they're still having severe pain at a week out, they probably need a recheck with their provider or with someone who can follow them up. So we move on to another case. 37-year-old male has a motor vehicle accident. He has a swollen wrist and a dislocated shoulder. He's actually on buprenorphine every day. How can we manage his pain? And what are the important points to remember about acute pain management for patients on buprenorphine or methadone? So for patients that are on buprenorphine, the first thing is keep them on the bup, keep them on the methadone. We see hospitals taking them off, and they really need to stay back on because it's really hard to get them back on the medication. Both bup and methadone have great pain effects, but they only last about 6 to 8 hours. So if the patient's taking all of their bup, most patients with methadone take it all in the morning, split it up while they're in the hospital. Divide it up Q6 or Q8, and you're going to have that total dose, divide it up, and start to give the patient kind of sequentially over the course of the day. The patient's going to have take advantage of the pain effects of that buprenorphine or methadone. Now with bup, you can also increase the dose by about 10%, or if the patient comes in, you can kind of sublingually maybe give an extra 2 milligrams every hour or so, every couple of hours, till their pain is a little better controlled. And you also can use the IV form, obviously kind of titrating to the patient's pain and somnolence. Methadone, you want to be careful. Methadone is a full agonist. It's very long acting. You can easily make someone stop breathing if you don't know how to use it. So if you're unfamiliar with methadone and a patient comes in, I'd talk to your pharmacist, maybe reach out to palliative care. A lot of times they are very well versed with methadone. You continue to use the non-opioid adjuncts, things like acetaminophen, ibuprofen, ketorolac, gabapentin if they're having some type of nerve pain, Zofran for vomiting, sorry, ondansetron, like things like trazodone or melatonin for sleep, diphenhydramine if the patient's, kind of agitated or has anxiety, tizanidine if the patient has some type of muscle spasms, and then obviously the nicotine replacement patch and gum, really important if the patient comes in using nicotine every day. You want to think about the newer options like IV lidocaine. We talked about that for kidney stones, low-dose ketamine, ultrasound-guided regional nerve blocks. Keep abreast of all these kind of new things that are coming out. And then if the patient needs full agonists, they may, especially for buprenorphine, it really gloms onto those opioid receptors. And so you end up having to use higher dosages. And the recommendation is really fentanyl or hydromorphone because it seems to be better able to give patients some pain therapy, even if they're still on buprenorphine. So keep the patient on the buprenorphine. Again, navigators. Some of these patients may be people that you know who come into the emergency room or hospital. If you see, hey, MVA on bup, motorcycle accident on Suboxone, go and introduce yourself and say, hey, I'm the navigator. How you doing on the Suboxone? Great, you're in recovery. I'm going to work to help you stay on your medication while you're in house. And then go talk to the team, talk to the nurse, talk to the doc, remind them that staying on this maintenance medication keeps the patient, their opiate use disorder at bay, keeps them out of withdrawal, and that it can be split again in order to take advantage of the pain effects. And you can use all these other things in order to help the patient's pain. So be that patient advocate. Next case is 65-year-old female, history of chronic low back pain. It's worsened over the last week. She is just distraught because her pain has been worse over the last year. She really hasn't been as active, hasn't been going out of the house, and she only sees pain in her future. And our question is, how should we think about chronic pain and how should we approach this patient? So I found this most fascinating. I learned a whole lot more about this in doing this lecture, and that's the biopsychosocial model of pain. I never learned any of this in my education. I don't think we teach our medical students enough of this. I don't think we teach our nursing students enough about this. And we certainly don't teach our patients about this. I work for a very large organization in Los Angeles, and I double checked with a couple of internal medicine friends who work in primary care, said, are we doing anything to educate patients in regard to the biopsychosocial model of pain and what they can do themselves to really decrease the pain in their lives? And the big answer was a big zero. The definition or a good quote is that pain is always a really personal experience that is influenced to a varying degrees by biological, psychological, and social factors. This could be an hour-long lecture of itself, hint, hint to bridge. But we're just going to top out it, kind of give you an overview and introduce the concept. So the three pillars of a patient's pain experience involve the biologic, which we typically know, right? That's the tissue and nerve damage or disease. And then what's also known as amplified CNS processing. We'll talk about a little bit more about that. Then there's the psychological, things like catastrophizing, your self-efficacy, mindfulness. We'll talk about a few of those. And then the social, socioeconomic status, whether or not you think there's healthcare discrimination, and the cultural factors. Again, we'll talk about a couple of these. This could be an hour-long lecture. I find it fascinating. So biological factors, the first of that pain experience. So we're all familiar with the nociceptive pain, that tissue injury, damage, or disease, such as fractures, sprains, or appendicitis. We're all kind of familiar with that type of pain. We're probably familiar with the neuropathic pain, that nerve injury. We hear about nerve pain being really more difficult to manage because it doesn't really respond to things like Tylenol and ibuprofen, things like diabetic neuropathy or post-herpetic neuralgia. It's this nociplastic pain that I really want to focus on a little bit more. This is this amplified CNS processing, or the patient feels more pain, and yet there's not clear tissue damage. There's not real clear nerve damage. All the imaging's back is normal, right? The MRI and CTs are normal, and yet the patient still is having pain. And things like that would be like fibromyalgia, low back pain, and IBS. So what is this nociplastic pain? So it's this amplified CNS processing or amplified pain perception without clear tissue or nerve injury or damage. Examples, fibromyalgia, IBS, headaches, interstitial cystitis, things like that. The problem is persistent and repeated pain from either tissue or nerve injury or damage causes structural, functional, and neurochemical changes in the spine and brain. Two ways. One, there's just increased excitatory signaling, so more pain is felt, and there's decreased what's known as descending inhibition. So less pain is inhibited. The body has these pain sensory pathways that go from the brain down to the periphery. And they're actually meant there to kind of inhibit pain, kind of tamp things down. They're supposed to prevent stuff from coming up. You've got this pain coming northwards and this inhibition going southwards. With this nociplastic pain, you've got increased signaling coming up and decrease of this tamping down of the pain going down. Functional brain MRIs show two things. One is increased connectivity between the parts of the brain that deal with pain and parts of the brain that deal with emotion. So more pain, more emotion, more pain. Bad combination. And decreased activity in the brainstem that have these analgesic pathways. We endogenously make opioids. They call them self-opioids or intrinsic opioids. We produce them when we're in pain. The problem is this nociplastic pain kind of cycle that patients get into decreases the amount of these endogenous opioids that are produced. Nociplastic pain is multifocal, it's widespread, it's more intense than we would expect it to be. Patients get hypersensitive to non-painful stimuli. So patients with migraines, if you guys have migraines, sometimes it'll hurt just to brush your hair. It shouldn't hurt to brush your hair, and yet it does. It's that hypersensitivity. It also causes fatigue, sleep disturbance, and cognitive problems. This type of pain responds much better to CNS acting medications like SNRI antidepressants, the serotonin, norepinephrine reuptake inhibitor antidepressants, and gabapentin. And we'll talk about that. And certainly things like exercise, sleep, cognitive behavioral therapy, and really kind of tackling the psych comorbidities like anxiety and depression in a patient really have a big effect on this type of pain. And we don't do enough education of all of this for our trainees or our patients. The psychological factors. So the whole left side amplifies pain. The whole right side actually protects about pain. We'll talk about a few of these. So the first is catastrophizing. If you haven't heard of this, it's basically thinking that your pain is a catastrophe, the worst thing ever. Patients tend to ruminate about it. They'll magnify it. They'll feel helpless about the pain. This then leads to anxiety, depression. The cycle just begins. This anxiety and depression then lead to a stress response, increased heart rate, your muscles tighten up, which is only worse for your pain, right? You make less of the endogenous or self-opioids, and you're now paying more attention to your pain, which leads to more pain and more catastrophizing. So patients get into this kind of vicious circle. The other vicious circle is known as fear avoidance. And so patients that catastrophize, they're like, well, if I go out and take a walk, I'm going to have more pain. So I'm just not going to do anything. I'm going to sit in my chair. Well, then they get deconditioned and their muscles break down and their joints get bad. And now they have worse pain. And so they get into this kind of vicious cycle of catastrophizing, not moving, and deconditioning. And again, it's something that we don't teach enough to our patients. But something positive. So there's something called mindfulness. We've probably all heard about it. We don't really know what it is. It's not just simply relaxing or ignoring the pain. It's really kind of turning our minds into the pain, turning toward the pain. The first is attention to the present moment. That's really kind of feeling the sensations in your body, including the pain, without putting all the labels on it, without saying this is terrible and I'm never going to get over this. The second is that kind of a non-judgmental observance, really kind of looking at it for what it is. And they talk about approaching pain with curiosity without fear. The next is acceptance without resignation, saying, yep, I have this pain, but you know what? It's not going to prevent me from living my life. I'm still going to go on that trip with my girlfriends. I'm still going to go to work. I'm still going to get up and walk around with my block, or walk around the block in my, near my neighborhood. It really gives a sense of empowerment to patients. And the next is decentering or disentangling yourself from the pain. The pain is not my identity. The pain is not who I am. It's something I deal with, but it's not who I am. And all of these things, and mindfulness is usually, it's taught by somebody, an educated person, like a clinical social worker, a therapist who's educated in mindfulness. It's generally kind of like an 8 or 10 week course. There are some online courses that can be done, but it basically produces more analgesia through one, it quiets the prefrontal lobe, so that area of the brain where all that catastrophizing and thinking is going on. And then it also weakens what's known as the thalamic somatosensory cortex connection. So all of the pain in the periphery of the body comes up to the thalamus, which is at kind of the base of the brain. The thalamus then sends these signals out to the cortex of the brain where all the thinking gets done. Like, okay, I just noticed that my knee hurts. What kind of pain is it? Where does it hurt? That's where all that is happening. If you weaken that thalamic somatosensory cortex connection, less signals are getting to the cortex and the patient experiences less pain. So this is, I think, is really something important for us to educate our patients. In fact, a lot of large organizations, American Family Physicians, American Pain Society, is really recommending that patients with chronic pain, especially low back pain, get educated in mindfulness because it's been shown to be very, very effective for patients with a chronic pain. Then there's the social factors. We're going to go over just a couple of these. We know that lower socioeconomic status is associated with higher chronic pain prevalence, greater disability, and obviously reduced access to multimodal pain medication. There was one study of 89,000 patients where if they had perceived healthcare discrimination, they had nearly 8-fold higher odds of severe pain compared to their counterparts who had really no clear discrimination or felt no real discrimination. The higher the patient felt about that discrimination, the higher their pain was. Cultural factors, pain expression, coping strategies, treatment-seeking behaviors, all vary across cultures. I found this fascinating. So Asian, African, and Northern European cultures, as a trend, tend to promote more stoicism, that pain should be endured, whereas your Hispanic, Middle Eastern, and Mediterranean tend to permit or even expect greater expressiveness to response pain. Doesn't mean they're feeling more pain. They're just kind of encourage more expression about the pain that they're feeling. African Americans, Latinos often prefer complementary alternative meds for mild to moderate pain. And I didn't really understand, I knew what I was seeing at work, but I didn't really understand why. Because a lot of our patients, when they come to my hospital, they've been in pain for a few days and they haven't tried anything. And I kind of want to say, you didn't try at least Tylenol? Now I understand why. They really save analgesics for severe pain. Interesting. And then we know that clinician implicit biases toward minorities, LGBTQ, and other marginalized groups really contribute to disparities. We need to educate our patients about pain, that pain does not actually mean you might have damage going on. Your imaging can be okay. Your CT and MRI might be normal, yet you're still having pain. We understand that. That stress, sleep, mood, social support, beliefs, all can have influence on the pain that you're feeling. The good thing is the brain can be retrained. The pain system can be retrained through graded activities, cognitive strategies, and lifestyle changes. That's what's known as neuroplasticity. And we really don't do enough to educate patients in our country about this. Sorry. These are just a couple of resources I found online. They were recommended by a number of organizations. I don't know where I put the books. I actually bought both of those books. They're workbooks. They look kind of fun. I don't think they're in Spanish, unfortunately, but I'm sure there's something out there. And then there's this website down at the bottom. It's called mypaintrainer.org. It's free. It's 8 sessions. It's online. And it actually was mentioned or actually studied in a JAMA article last year known as the Resolve trial. And they found significantly greater rates of clinically meaningful pain improvement at 3 months and sustained at 12 months, with outcomes similar to people that did a mindfulness, this kind of learning about biopsychosocial resources and pain management that they did by themselves compared to those with a kind of a health coach. The outcomes were really the same. And again, this is a shout out to the navigators. Put together some education, make a brochure again of, what are the local places that they can go for yoga? Where can they do free swim lessons to get some aquatic kind of energy? We talked about downloading some music therapy with QR codes. Let them know about the pain resources that are, available by books, maybe in Spanish. Educate them about this mypaintrainer.org website. There are a lot of other resources online. And then the navigators are really got a key patient educator that we can use on our hospital. So I'm going to give a shout out to the ones in the audience. Put together some training, put together a brochure, work with your hospital and your clinic, because you can really, this is probably the only education the patient will ever get regarding this really important aspect of pain management. Chronic pain, how do we measure? We really need to focus on function and quality of life. Traditional acute pain scales are like 0 to 10, right? What we really should focus again is how is that pain affecting my life? This is one tool that we use in our hospital. It's called the PEG tool. Again, you're asked 0 to 10 in the last week. How would you describe, what best describes your pain on average? What best describes how pain has interfered with your enjoyment in life? And then what number describes how pain has interfered with your general activity? Again, it's a scale, but it really focuses more on function and enjoyment. And so if the patient then goes on and does mindfulness, or they go to PT, or they start doing yoga, you can then use the scale longitudinally to kind of reevaluate their pain and see if there's some of these things are making the pain and the enjoyment and the function of their life a little bit better. Again, long list of kind of non-pharmacologic ways of treating patients' pain for chronic or subacute pain, things like exercise, yoga. Again, that shout out to the navigators. Find the free swim lessons, find the free yoga. LA Care in Los Angeles, the health plan has a lot of free kind of in the park programs, yoga programs, all sorts of physical programs for patients. And I'm sure your health plans may be doing the same. You just have to find out about them and then educate the patients about them. Things like physical therapy, acupuncture. Medi-Cal pays for a certain number of sessions of Medi-Cal. So you can tap into that for your patients. Massages, behavioral therapy like mindfulness and CBT we talked about, and then just self-care, weight loss. A lot of chronic knee pain would probably go away if people lost weight. And sometimes patients don't want to hear that. Swimming is a good way to kind of lose that weight because you're buoyant and you're not really putting that weight on your knee. Sleep hygiene, smoking cessation, making sure your desk at work and your chair at work fit you and it's not giving you chronic low back pain. Again, your navigators, education, education. Put together a little brochure of what's available in your community for patients that may be free and maybe in Spanish. So we're talking about meds now for chronic pain, and you'll see NSAIDs are still there, not so much Tylenol, but really what is now coming into play are these gabapentin and the SNRI, specifically duloxetine, because that's one of the ones that has been FDA approved. Things like osteoarthritis, low back pain, diabetic neuropathy, IBS, fibromyalgias, and migraines. So I want to talk a little bit about that neuropathic pain and the nociceptive pain and why are they responsive to antidepressants? So duloxetine is known as an SNRI, a serotonin norepinephrine reuptake inhibitor. Basically, it increases the happy hormones around the serotonin and norepinephrine. That's what increases people's mood who are using it as an antidepressant. Well, it's also FDA approved for diabetic peripheral neuropathy, chronic MSK pain, and fibromyalgia. And it originally was thought, well, you're just making people happy. They don't care about their pain because they're happy. No, it actually is more nuanced than that. They've discovered that serotonin and norepinephrine actually enhance, remember those descending pain inhibitory pathways? It actually enhances that in the brainstem and spinal cord. So it results in suppressing pain signaling from the periphery. Pretty good. The numbers needed to treat, and that means how many people with chronic pain would you have to treat with an SNRI to help one person? The numbers needed to treat is 6. That sounds high. It's actually really, really good. Patients that come into the emergency room with a heart attack, we give them all an aspirin. You have to give 50 people, 50, an aspirin who is having a heart attack to help one person. Yet we give them to everybody. So numbers needed to treat is 6. It's really pretty good. All right, next case. We're kind of going to wrap up with this. This is a 32-year-old male, history of sickle cell. He's complaining of kind of an acute pain crisis. He's had multiple visits to the emergency room for pain. He's had difficulty with transportation. He's got like a necrotic hip, so it's really hard for him to like sit in a car. So he's missed a lot of his appointments. And you overhear the RNs complaining about this patient as a hard stick. Man, he's here all the time. You know, he's just here for Dilaudid. And after 2 hours of waiting for pain meds, the patient asks to see his doctor. I want to end with what I'm going to talk about is we're not all treated equally. So we know that certain groups are actually at risk for undertreatment. And this is where I'm going to give a shout out again to the navigators. Look out for these patients. I know navigators, again, are seeing a lot of patients in the ER that aren't just substance use. They're seeing people that are unhoused. They're seeing people maybe with mental health issues. They're seeing the people with, chronic visits to the emergency room. Be that advocate for these patients that get undertreated. So Black and Hispanic patients, people of color, are less likely to receive analgesia for acute pain. In all pain studies, patients of color lose out entirely. There's a very embarrassing study in 2016, it was 10 years ago, where white medical students and residents were asked questions about patients of color, and they endorsed false beliefs regarding biological differences between Black and white patients. Like, for instance, Black skin is thicker. This is ridiculous. This was 10 years ago. We have a lot of work to do in educating our healthcare trainees around patients. These same students and residents rated pain scores lower in the people of color, and they made less accurate treatment recommendations. Again, a completely embarrassing study for our healthcare education system. We know that older patients with dementia are less likely to report pain presence. and they're less likely to get over opioids compared to your people who have cognitive, are cognitively intact. So look around for that elderly person that's there with a hip fracture and make sure your docs have prescribed a pain medicine and that somebody's gone back to make sure that the pain medicines have actually taken effect. Patients with substance use disorder, everybody wants to chalk up whatever they come into the ER with, well, you must be in withdrawal. No, they still can have an ankle fracture and be in pain. They still can have abdominal pain and be appendicitis and need pain medicine. So it's not all roads lead to withdrawal. So again, patients with substance use disorder less likely to receive treatment. If you have limited English proficiency, they're less likely to have thorough pain assessments, get fewer opioids. And then in minority patients, obviously your LGBTQ, your marginalized groups are at risk for bias for staff with patients coming into the emergency room. Again, navigators, these are your people. Advocate, look around on the tracking board, see the patients that maybe you've seen them in the emergency room before. Walk around the emergency department, see what patients are there for. Be an advocate for pain management. In 2020, the American Society of Hematology put together this it's about 50 pages regarding sickle cell disease. If you work with a lot of sickle cell patients, I highly recommend you read it. It's everything from ER, inpatient, clinic care. So just highlighting some of the things based on the case that we talked about. So their recommendation is you get analgesia in the patient within an hour of arrival. You'll get the patient out faster. They want reassessments every 30 to 60 minutes. They want individualized care plans. And this is where I'm going to step away and just say for a second, I want to give a shout out to a teacher of mine when I was in training, Marshall Morgan, rest in peace. He was an amazing teacher, and he really advocated for patients with sickle cell disease. And he equated it to living with a battering husband. So a woman who lives with a battering husband wakes up every day and says, is today the day he's going to beat me up, where I'm going to suffer severe pain? Patients with sickle cell wake up every day with the same thought. Women who live with a battering husband wake up every day and say, is this the day he's going to kill me? Right? Because a certain percentage of women are going to be killed by their battering husband. And patients with sickle cell have that same thought. Patients with sickle cell live generally 20 to 25 years shorter than patients without sickle cell. And so once we started thinking about patients with sickle cell as living with a battering husband, it makes you a lot more sympathetic, right? Unfortunately, they're mostly patients of color. They live in healthcare deserts where they don't have access to primary care, right? There's one doc for thousands of patients, and we put them on opioids, and then we call it a day, right? These patients are set up to fail by the healthcare system we have. The recommendation is that you have an individualized care plan. You know that Joe Smith is going to come in, have a plan that works for him. We always get mad at patients and say, well, he's asking for 2 milligrams of Dilaudid. If you had a chronic condition yourself that caused severe pain at times, and you knew exactly the pain medicine the doc needed to give you in the ER to make yourself feel better, you would say something. And so for us to chastise people that come in and say, I know what will work for me, is ridiculous. And so make sure that we have that individualized care plan, not weight-based dosing, individual care plan. We need to educate patients. We're starting them opioids. We're giving opioids in the ER. Make sure they know about the limitations and the harms about opioid treatment. ED order sets for sickle cell, having all the non-opioids, opioid ways of treating patients' pain, admission orders, all that kind of stuff has been shown to save admissions and improve satisfaction. The recommendation is to start NSAIDs for 5 to 7 days in addition to anything else that you're giving, making sure you're looking for risk of renal, GI, and cardiovascular effects. Intranasal fentanyl. These patients are hard sticks. They've been in the ER a lot. They have no more veins, right? So use intranasal fentanyl. We do it in kids all the time, and it works really well in adults. In fact, some hospitals have a nurse protocol. Patient comes in with sickle cell. They have a care plan. They're otherwise stable. The nurse can, based on a driven protocol, start acetaminophen, ibuprofen, and intranasal fentanyl without a doctor's order, based on protocol. Get those medications in the patient quickly. Things like low-dose ketamine are recommended, regional nerve blocks, all of those other non-opioid ways of treating patients' pain. And then lastly, you really want anybody who's on, I just gave an example of sickle cell because I find it's the most stigmatized group, I think, of people that come in with chronic pain. But anybody with chronic pain who's on chronic opioids, some percentage, a tiny percentage, are going to have an opioid use disorder. And you want to keep an eye out for them. And that's really, again, a shout out to the navigators. The use of chronic opioids will result in physical dependency and tolerance. Like I said, even if they take it as prescribed. And I get residents all the time saying, this guy's in withdrawal, he must have a use disorder. No, that alone is not enough. It is for alcohol. If you're in alcohol withdrawal, you probably have a use disorder, pretty much. But even as with opioids, if you take as prescribed by your doctor, not another dose, you will become physically dependent if you're on it for extended period of time. And so physical dependence and tolerance alone is not opioid use disorder. You need all that other negative stigma, or sorry, negative, things that happen in the patient's life. They've lost their job or their kids. It's affected their work. They've had, physical ailments. They've had endocarditis from their drug use. They've had liver disease because of their alcohol use. You have to have all that other stuff in order to really define it as a use disorder. You continue to use despite all the negative effects that it's had on your health and your family and your life. If you are worried, you want to approach the patient, open and caring. I pull a chair up. I say, I just want to have a conversation. I want to make sure you're okay. You can ask things like, have you ever taken pain meds when you're not in pain to sleep, handle stress, or mood? Have pain meds caused problems in your life? Is the opioids you're on has caused a problem with your relationships, your work, your daily responsibilities? When you come to the ER, what are you hoping to get? Is it a specific pain medicine, or are you open to whatever treatment works best? If I were to tell you there's a new medicine out there that works incredibly well for acute sickle cell pain, it's not an opioid, would you be open to it? When your pain is well controlled at home, do you still think a lot about your pain meds? When your next dose is, whether or not you have enough? And have you ever obtained meds from someone other than your doctor, friends, family, or on the street? The patient may not be open to this on the first visit. Remember, they're sometimes coming in with both hands up because they have been so stigmatized. Patients who have chronic pain and come in and again, like that scenario again, that's a lot of what they hear. That's a lot of what they experience. And so they're waiting for anybody that comes in that room to be mean to them and say, why are you here? You need to get out, right? Why didn't you go to the clinic? Why can't you get to your appointments? And stigmatize them and berate them. They're not ready for someone to have an open, caring attitude. And so it may take a few visits, sometimes seeing that same navigator and having that conversation. And then if they're amenable, switching to buprenorphine is going to be safer, a lot less respiratory depression. Sometimes just switching over to bup can reset the pain receptors. It's a really safe and really strong, powerful pain medicine, in addition to getting them into longitudinal maintenance, pain treatment with, in like a sickle cell clinic or with the hematologist. Again, a shout out to the navigators. Look for these patients who come in with chronic pain. You know their names. You hear the staff talking about these patients and really kind of reaching out to them and saying, hey, can I have a conversation with you? Maybe there's a better way. And again, it may take several visits to kind of break down those barriers. So in summary, I want to say you want to treat pain with the same respect as we do other conditions. We need our hospitals to do it. In my organization, we just recently hired pain physicians just in the last 3 years. Yet we've had every other specialty known to mankind. We need to educate patients about the biological, psychological, and social factors. We need to educate providers and staff and healthcare providers. We don't do this enough. We need to check our bias at the door. We need to watch out for untreated groups. Again, undertreated groups. Again, our navigators can be those eyes and ears. We need to use non-opioid, non-pharmacological ways of treating pain first. We need to stay current on the newer ways of treating pain, such as SNRI antidepressants, low-dose ketamine, intranasal fentanyl, ultrasound-guided regional nerve blocks. When opiates are used, we want to review the risks and benefits. We want to use the lowest dose of immediate release forms, and then we want to limit that number of tablets of the prescribed for acute pain, generally about 3 to 5 days. Then they need to get a recheck. And then for patients on chronic opioids, keep an eye out for signs of misuse or opioid use disorder. Remember, it may take a few times of really interacting. Maybe that patient seeing the same face or the same approach by staff. Use open, non-stigmatizing approaches and consider switching them over to buprenorphine. And these are my references. And with that, I will say thank you. And this is our California Bridge website. We have a lot more education that is available online. We offer CE for nurses and CME for healthcare providers. And with that, I say thank you.
Mo, we do have some questions in the chat. Do you have a few
Okay,
minutes to
sure,
uh,
absolutely.
so I can read some for you. There is a
Okay.
question that says, we may have missed the definition of navigators. Is it a California hospital requirement?
Okay, so there's not. I wish there was a hospital requirement. There isn't. So about 7 years ago, California Bridge got into the addiction space. And one of the things that they realized was that we needed to have, it's not good enough just to educate the nurses and the doctors about, hey, let's prescribe buprenorphine, but we really need to baton pass that patient to a clinic who can continue that care. Um, Addiction is a disease of executive functioning. This is not a patient population that you can just say, hey, here's a phone number. Why don't you try to call and make an appointment? They just can't do that. Addiction affects the reward centers of the brain. So there's that constant I need that is so powerful, and the patients just can't control it. That's why it's called an addiction. And then it kind of affects that frontal lobe of the area of the brain where all that kind of executive functioning and thinking do. So like making appointments and keeping appointments, not something they do well. And that's why having a navigator there that can be that bridge between the patient and the clinic, and doing a three-way call and arranging an appointment before the patient leaves the hospital, or calling the patient the next day and say, hey, let's get you plugged into treatment. I saw you were in the emergency room last night and you got Suboxone. That's what navigators are for. Now in California, Medi-Cal will pay for what is known as community healthcare workers, CHWs, to work in the ER, and one of their jobs can be as navigation for these patients. It takes some billing of Medi-Cal. It's still being worked out at the state level, but hospitals are doing it. There are organizations, nonprofits, that will bill Medi-Cal and put CHWs in your emergency departments to work as navigators. And Bridge, for any hospital that's interested, Bridge can give you more information about that.
Thank you. We have another open question. Is bupe alone or with naloxone recommended to reset pain receptors?
So it's interesting. Naloxone itself has been looked at, and actually naltrexone too, low-dose naltrexone, because those are opioid blockers, right? Narcan and naltrexone are opioid receptor blockers. Narcan is what we use to wake people up after an overdose, and naltrexone is one of the drugs that is FDA approved for opioid use disorder, and really actually works really well for alcohol and meth use. It blocks the opioid receptors. The buprenorphine and naloxone combination, the naloxone there is not needed for, that's not the intent of it. Maybe it has some effect on that, but what the naloxone molecule and buprenorphine is there for, and in the trade name is Suboxone. Subutex is one of the brands where the naloxone isn't there. The sole reason the naloxone molecule is attached to the buprenorphine is to prevent diversion. The theoretical thought is you could take the tablets and the film, crush it. If you put naloxone under your tongue, with the buprenorphine, like Suboxone, it's inert. It's not going to work. If you swallow it, it's not going to work. But if you take that film or tablet, crush it, and inject it, the theory is that naloxone will then put them in withdrawal, and they won't be very happy. The amount of withdrawal they get put in is apparently not a lot. The buprenorphine they have kind of overrides it. So I think it makes us feel better than actually being a true diversion. But that's why the naloxone molecule is there. But you're right, whoever asked that there is some, and it's again not an area that I'm particularly knowledgeable at, but I know that there's some thought that putting people on low-dose naltrexone and naloxone can reset those pain receptors that then opioids in the future or other medication may actually work better. So that's the first time I've been asked that question. That's a good question.
Thank you. We have one more open question from Melissa Baker. Would you start an SNRI in the ER?
Yes, I do, but it's not something that we train emergency department patients do. If we get a lot of people, most of the patients we see, we see acute pain, but we get a lot of people with chronic pain, especially now. I just saw an article saying that because of the healthcare cuts that are going on in the country and the loss of Obamacare, there's a lot more people coming to the emergency room, and they're going to be there with chronic pain. So absolutely, you could start someone on a low-dose NRI, duloxetine specifically. Again, kind of looking, are they already on an antidepressant? You want to make sure you know that their pain history, maybe take a little bit of, if they come in suicidal, obviously we're going to get psych involved with the patient. Some people may come in and say, I'm having so much pain, I can't stand it anymore. But yeah, generally, it's something I feel really comfortable at starting at, but we don't do enough education of our emergency medicine physicians for that. We need to.
Thank
Is
you.
that it? All right. Well, I really want to thank you guys. And this was great. I really appreciate your attending, and I hope you got some education out of this.
All right. I see one last question that just came in. Do you have a
Okay.
minute?
Uh-huh.
What are feelings of starting someone on bupe to get them off long-term opiates? Have had some patients say it isn't enough. What would you add to it?
So it depends on the dose. Generally, people that are on long-term oral, if you're talking about long-term pain management, like oral pills that they've been on, switching over to buprenorphine, there's a couple ways to do it. They either come off the opioids, get in a little withdrawal. That's the problem with bupe, is you have to be in a little withdrawal in order to start it because it's this partial agonist. So people have to come down a little bit. There's another way to do it where you kind of microdose the buprenorphine. Buprenorphine is an extremely powerful pain medicine. If it didn't work, then my guess is they're having some type of neuropathic pain, or maybe they got this nociplastic pain situation going on where an SNRI may be more helpful, or gabapentin may be more helpful. So it may be that we just need to do a deeper dive into what type of pain the patient is actually having. Buprenorphine is not going to be good for all chronic pain. Again, starting someone on an opioid for chronic pain is not recommended. But if somebody has been on it for years, getting them down to like a dose that's safe is certainly recommended. And then buprenorphine, switching over to buprenorphine, also a lot of places are doing it's not mandatory, but it is a safer medication in regard to the respiratory depression. My guess is if the buprenorphine didn't work, it's chronic pain and opioids don't work a lot to begin with. Or maybe they're having some other type of pain like neuropathic or the nociplastic pain where opioids aren't going to really work.
Thank you.